Hello all, I'm going to talk about chest x-rays and the interpretation of common pathologies that we see in intensive care unit. Besides the chest x-ray topic, I'm also going to cover CT scans of the chest as well. Now this particular talk is certainly not groundbreaking, and it is more so to enumerate the pathologies, what is expected when you describe them, and how to go about the business of reporting on chest x-rays. So let's get into it. Now, we intensivists order routine anterior-posterior chest X-ray for most of our ICU patients and review them as part of our daily routine. Now, this has come about because of a number of concerns that have been raised over the years. One of the main things is that there's a lot of complexity of medical interventions that patients undergo while they are in intensive care unit. It also makes it easy for us to detect complications associated with indwelling devices, which might be central line catheters, endotracheal tubes, chest drains, ECMO cannulas, balloon pumps, and so on and so forth. As well as it is also important for us to um, kind of report on the progress of the cardiopulmonary illness as well as the severity of the cardiopulmonary illness. Now, because of the complication rates of number of devices such as device malpositioning or pneumothoraces, some of the guidelines have come out and said that routine anterior-posterior chest X-ray should be routinely performed in intensive care unit if the patients are receiving mechanical ventilations or patients are acutely unwell with acute cardiopulmonary problems. That there's significant advantages to having routine chest X-rays, such as you can promptly detect complications, you can treat the complications quite early. You can also it also helps us to document the disease progression as well as response to therapy. Um, we certainly cannot rule out the educational value of the chest X-rays have to teach trainees, residents, as well as medical students. But there are lots of other people who believe that there are way too many X-rays being performed in intensive care, and we should probably follow a restrictive strategy and limit the number of X-rays that we perform. And the reason why we should perform X-rays is if there is a clinical change or change in the clinical status of the patient, or if we have done certain procedures. Now, arguments for adopting such a restrictive strategy is because the interpretation of chest X-rays within intensive care unit can be variable depending on who looks at the chest X-rays. It might be a trainee who might be the first person who looks at the chest X-ray, or it might be a consultant, it might sometimes be only a resident who looks after the chest X-ray. Now, there is also, if you look at the volume of the chest X-rays being performed in a unit, there is a lower incidence of clinically unsuspected abnormalities, especially after a good clinical examination, and therefore it is very infrequently that you will actually do certain things after a chest X-ray has been performed. There is obviously potential harm while performing a chest X-ray, not only from radiation exposure point of view, but also from the point of view that you have to modify the patient's position, and it might result in inadvertent extubation or inadvertent central line removal, or yeah, and it can be quite disastrous if you think about it, if there is a manipulation of an ECMO cannula or of a VASCAD while the patients are still on the dialysis machines. Um, there's obviously other potential harm can arise from um, of a wrong reporting or a minor reporting of a minor abnormality, which might result in risky interventions, such as people might try and put a chest drain into small pneumothoraces in patients and cause more problems than the initial therapy would have been required. Similarly, pleural effusions in chest X-rays get reported way too often. Then there are significant pleural effusions, and people might try to put chest drains into patients who are having collapse rather than pleural effusions. I certainly believe that there are way too many X-rays being done in intensive care units, and we definitely need to reduce the number of X-rays that we perform, especially for patients who have been cleared for days. And anyways, that particular discussion is for another time. What we will do is we will talk about how to read a chest X-ray, um, the details about the basic things about reading a chest X-ray, anatomy of a chest X-ray, and then we'll go through certain pathologies as we go along. Now, there are various methods by which people have described how a chest X-ray can be appropriately described. There are lots of mnemonics out there. There are lots of blogs, and there are lots of formatted articles about reading chest x-rays, and I'm not going to say one is better than the other, and I'm not going to say that my method is the best method as well. You can follow whatever suits you. You can, if you've been following a particular mnemonic or a particular way of describing the chest x-ray, keep doing so. There are certain principles, however, that I would like to share with you. um, Especially in the exams, it's important that you basically go through some basic things, such as, for example, you need to make sure that there is an adequate patient data recorded. Make sure that you look at the history and the associated information that is provided at the start of your X-ray interpretation. It will help you narrow not only your differentials but also help in result in better presentation. The next step would be to obviously look at the image quality, including inclusion, projection, rotation, inspiration, penetration, and artifacts. And we'll basically talk about that in a bit more detail in the next few slides. Then the next step is, there's a lot of people who believe that the equipment should be described way too early, and I think that's probably a wrong way of doing it, because you would be expected to touch upon the obvious abnormality that you can see right in front of you. So if there's an obvious tension pneumothorax or a large pneumothorax, it is important that you describe that way before you start describing the equipment. So the try and describe the obvious abnormality. Make sure when you describe the obvious abnormality to talk about the localization, whether it's a right-sided or left-sided, lower zone, upper zone, mid-zone, so on and so forth. Describe what the pathology you see. You see a consolidation, you see infiltrates, you see um, nodules, or you see cavities, or whatever it is. You make sure that you describe it well, and then obviously try and give differentials to the abnormality. Um, the next step would be to do a structured approach at looking at everything else, which means describing the rest of it, including lung fields, heart shadows, diaphragm, costophrenic angles, ribs, vertebral shadows, whatever it is that you want to describe. I have a structured approach, and we'll go through that in the next few slides. And then obviously talk about the hidden areas, and we'll go through that as well in a few slides. As far as the image quality is concerned, the first step is to look at the inclusion. Now, inclusion is nothing but how much of the chest cavity or thoracic cage is visualized on the chest X-ray. A chest X-ray ideally should have the entire thoracic cage, especially the first ribs, costophrenic angles, and the lateral edges of the ribs, well visualized. Now, in the first chest X-ray that you can see, which has been labeled as good inclusion, you can see the first rib, you can see the costophrenic angles as well as the lateral edges of the ribs, and therefore it's called a good inclusion. The second X-ray, on the other hand, you can't really see the first rib. You can not visualize. You cannot visualize the costophrenic angles, and therefore it's not a good inclusion. It doesn't mean that you can't report on this X-ray. The second X-ray, which doesn't have a very good inclusion, demonstrates a right-sided pneumothorax, and therefore it would be expected of you to still report on the pneumothorax, even though it doesn't really show you the costophrenic angles well enough. I hope that that clears it. Um, the next step would be to look at the in terms of image quality would be to look at projection. A projection of a chest X-ray could either be a posterior anterior chest X-ray or an anterior posterior chest X-ray. In a posterior anterior chest X-ray, the X-ray beam travels from the back of the patient onto an X-ray film, which is placed close to the patient's chest anteriorly. In this, the source is always kept at a much larger distance from the patient. On the other hand, in the anteroposterior chest X-ray, the X-ray beam travels from the front of the patient onto the X-ray film, which is placed close to the patient's back posteriorly. In this view, the source is always kept at a much shorter distance from the patient. Now, because of this particular reason, the chest X-ray does appear a little bit different. And the main thing that happens with an anteroposterior chest X-ray is that it results in magnification of the heart shadow due to the closeness of the heart with the X-ray beam source, and due to the reduced distance that the X-ray beam has to travel between the X-ray beam source and the patient's chest, and it results in a divergent beam, as is evident on this particular film, where the faint blue shadow, which indicates that the heart actually looks a lot bigger even though the size is exactly the same and it's from the same patient. On most occasions, the chest X-rays are usually labeled as whether they are AP films or PA films, but on certain occasions they might not be labeled or they might be cut off, and therefore you might have to actually make the decision as to whether it's an AP film or a PA film. But on most occasions in ICU, you would expect the films would be an AP films because you can't necessarily get PA films in an intensive care unit. So the way to look at if it's a PA or an AP film is to look at the scapular borders. If the scapular borders are pulled around laterally, it is more likely to be a PA film, as is evidenced on the first X-ray, where the scapular borders can be seen at the edges of the lateral ribs. On the other hand, if the scapular borders are well visualized, then it is likely to be an AP film. And most of our ICU X-ray films are anyways AP films, so you would be able to visualize the scapula in entirety on these films. The third point when we talk about image quality is to look at the rotation. Now, when we talk about rotation, we need to first of all have a look at two specific bony shadows: the medial end of the clavicle and the vertebral spinous processes. The medial end of the clavicle should be equidistant from the spinous processes. If they're not equidistant, it indicates that the chest X or the X-ray film has been a rotation. If the patient is rotated, then the interpretation may become difficult, especially in relation to the fact that the trachea might be deviated, and it's difficult to know whether the trachea is deviated because of rotation or because of the pathology, or sometimes the rotation of the film can also result in abnormal heart shadows, or especially magnification of the heart shadows, and therefore the heart might appear bigger, and therefore it might be difficult for you to make a specific interpretation on the heart shadow if the film is rotated. There could also be some soft tissues which are overlying the chest and not necessarily within the thoracic cavity, which might actually appear to make wider images on the lungs, and it might be difficult for you to say whether it's because of the soft tissue shadows or because of actual pathology within the lung fields. Next step would be to look at the inspiration. To check for the adequacy of inspiration, it is conventional to count down ribs anteriorly right up to the diaphragm, and usually if you think about the diaphragms, the mid-clavicular line is usually intersected by either between 5th or the 7th rib anteriorly. That indicates that there is an adequate inspiration. If you see less number of ribs anteriorly, as is evidenced by the second film, it's intersected by the fourth rib anteriorly. It indicates that there is poor inspiration. On the other hand, you might be able to visualize more than the standard 7 ribs anteriorly. It indicates that there is a hyperexpansion of the lungs. When there is hyperexpansion of the lungs, it also results in significant flattening of the diaphragms, as is visualized in this particular X-ray, where the diaphragms have become really flat, and it indicates that there is hyperexpansion of the lungs. The heart shadows also looks quite thin and small. The next step in looking at image quality is penetration. Now, penetration is the degree at which the X-rays are passed to the body. Now, assessment of penetration is traditionally a standard part of assuring chest X-ray quality. However, it's no longer as necessary as it was maybe in the past, because we now have digital X-rays where we can actually change the exposure by just a click on the computer, and therefore it's no longer as important as it was in the past. The most important thing to remember is that the overexposed X-rays look darker than normal. Therefore, the fine details are very hard to visualize. Like in this particular, on this slide, you can see the third X-ray. It's all appearing very dark. You can't really see the rib shadows very well. On the other hand, the underexposed X-rays, the one on the left, shows that they appear a lot whiter than normal, and therefore some of the abnormal opacification might be very difficult to differentiate from normal tissue. Now, the way to tell whether the exposure is adequate or not is by looking at the intervertebral bodies and the pulmonary shadows. Now, if you can see the pulmonary vessels and the vertebral bodies quite well, it indicates that it's a normal exposure. On the other hand, if you can't really see the vertebral bodies, it indicates that it is an underexposed X-ray, as is clear on this left-sided X-ray. On the other hand, if you can see the vertebral bodies quite well, but you can't see the pulmonary vessels, it indicates that it's an overexposed X-ray. The next step will obviously look at the X-ray anatomy. Now, there are many structures in the chest that will be visualized on a routine chest X-ray, but there are lots of other structures that are there in the chest cavity, but we can't really see them on a chest X-ray. The easily visualized structures include the trachea, the hilar fields, the lung fields, diaphragm, heart, aortic knuckle, ribs, scapular borders, breasts, gastric bubble and the bowel gas. And the poorly visualized structures include the esophagus, aorta, pleural line, sternum, spine, as well as fissures. Let's go through some of the anatomy. Now, the trachean airways are large airways, and they're very well visible on most good quality chest X-rays. The trachea obviously has air, and therefore it appears blacker than the surrounding soft tissues. The trachea branches at the carina into the right and the left main bronchus, and on most X-rays you will be able to visualize the right and the left main bronchus quite well. Beyond that, it's a little bit more difficult on most X-rays, but on some of the X-rays you may be able to visualize the branching of the right main and the left main bronchus into smaller bronchi. If the trachea is deviated, it's important to determine or establish whether it's because of rotation of the film, again looking at the distance between the medial ends of the clavicle and the vertebral spinous processes, or on occasions the trachea might be deviated because of actual disease process such as collapse, or pleural effusions, or even pneumothoraces. Next things are the hilar structures. The hilar structures are complicated structures mainly consisting of the major bronchi and the pulmonary veins and the arteries, and these structures pass through a narrow hilar on each side and then branch as they widen to the lungs. The hilar is usually not symmetrical but contain the same basic structures. Usually, if there is an enlargement or more visualization of the hilum, it's usually because of hilar lymph nodes. Again, reporting on hilar lymph nodes is not necessarily what you're going to do in the exams or even in routine practice, and therefore we'll probably just ignore these things. Hilar points might sometimes be visualized, but on most occasions they're again not visualized, and again these hilar points are specifically important to report on hilar lymph nodes, not so much so to do with us anymore. The next step would be to look at the lung zones. Now, it is difficult to put the whole of both lungs in your field of view, and therefore it's important to differentiate between the upper, middle, or separate the lung into three different zones: the upper, middle, and the lower zones. The lung zones do not equate to the lung lobes. For example, the lower zone on the right side includes middle as well as lower lobes. And each zone is compared to when you're describing infiltrates or anything on the or disease process on one zone, you need to make sure that you're looking at or comparing it with the other side as well. Now, if look at whether there is if these abnormalities are symmetrical or asymmetrical, as well as if there is if it's white or dense in appearance, or whether it's black in appearance. In most pathologies, the lung fields will appear whiter because of either infiltrate by pus, blood, or fluid, and very rarely you will see that the abnormalities are blacker or blacker in appearance, especially within the lung fields. This may, however, sometimes happen, like in presence of cavities, abscesses, or even sometimes because of a ball valve effect and hyperinflation. You need to make sure that you're describing it in zones rather than lobes. The lungs are obviously, we know that the lungs are divided into normally into lobes, and on the right side we've got three lobes: the right upper, middle, and the lower zone. If you see an anterior posterior chest X-ray or a PA chest X-ray, um, the right um, the right hemithorax is predominantly made up of a right upper lobe and a small portion of the right middle lobe and a very tiny portion of the right lower lobe in the costophrenic angle, while the left lung is normally divided by the oblique fissure into a left upper and a left lower lobe. The left upper and lower lobe, again, if you look at the anterior posterior or posterior anterior chest X-ray, majority of the left hemithorax is formed by the left upper lobe and a very small portion by the left lower lobe in the left costophrenic angle. The right lobe is divided into these three lobes by the horizontal and the oblique fissure, which are well visualized on the lateral chest X-ray. Costophrenic angles and recesses. The costophrenic recesses are formed by the hemidiaphragms and the chest wall, and they contain the rim of the lung bases that overlie the dome of each of the hemidiaphragm. The costophrenic angles, on the other hand, are made up of the lateral chest wall and the dome of each hemidiaphragm. And you can obviously visualize these costophrenic angles, both the right as well as the left side. And on the lateral chest X-ray, they're both anterior as well as posterior. Blunting of costophrenic angles is normally seen in pleural effusion, but however, it can also be seen in conditions such as collapse or even consolidation, or sometimes with infiltrates. But it's also important to remember that the costophrenic angles also lose their acuteness in conditions such as hyperinflation, where the diaphragms are pushed downwards and there is flattening of the diaphragm, making the costophrenic angles blunt. Next step would be to see what the heart size and contours mean. The heart size is usually not described in absolute terms, and majority of the times it's compared with the thoracic width. And therefore, what we do is we actually do a ratio of the cardiac and the thoracic width. And this ratio normally is less than 1:2, which means the cardiac width is less than 50% of the thoracic width. If it's larger than more than 50%, or the ratio is more than 1:2, it indicates there is enlargement of the heart. Again, this has to be described only on posterior anterior chest X-rays and should be avoided in anterior posterior chest X-rays. However, on occasions, you may get an extremely enlarged heart on an anterior posterior chest X-ray, and make sure that you actually describe that in that situation. Diaphragms, we obviously see the right as well as the left diaphragms, and just under the left diaphragm you can definitely see the gastric bubble. You may see the aorta, ascending aorta, and the aortic knuckle. The aortic knuckle represents the left lateral edge of the aorta as it arches backwards, and this can make a small angle with the left pulmonary artery, which is called as the aortopulmonary window. Again, aortopulmonary window is a recess where you sometimes can get pathology and such as lymph nodes, or even sometimes you can get lack of this aortopulmonary window when there is an aneurysm of the aorta. In the lack of aortic knuckle or blunting of these borders of the aorta can be present in patients with aortic aneurysms. Obviously, you will have to describe bones in detail, including ribs, clavicles, vertebral bodies, as well as scapula. And finally, equipment. When you talk about equipment, there's a number of equipments that you can normally see on a chest X-ray. In this particular chest X-ray, you can visualize the endotracheal tube, the pulmonary artery catheter, which seems that the tip is going into the pulmonary artery, the intra-aortic balloon pump, which is in an inflated position where the tip is actually just under the left clavicle, chest drains, and sternal wires. You may also have to describe the chest drains in detail, as well as on occasions you may also see things that you haven't seen on the routine chest X-ray at your place, and this includes a ECMO cannula which is sitting in the IVC. Also, you may be able to visualize an Avalon VV ECMO cannula on occasions, which is going from the right internal jugular vein into the patient's SVC and then into the IVC. So you'll have to describe all these equipment, and we'll go into details about these equipments as well in the next few slides. Well, that's all to do with anatomy. Let's talk about, in relation to the anatomy, let's talk about something that we commonly come across when we're talking about chest X-rays, and that's Silhoutte sign. Now, Silhoutte sign is nothing but a misnomer. It should be called as the loss of Silhoutte. Now, normal adjacent anatomical structures of different densities usually form a crisp Silhoutte. Like for example, on a normal chest X-rays, the heart is usually white. The hemidiaphragms and the abdominal structure appear a lot whiter. On the other hand, the lungs have air in them, and therefore they will appear darker, and therefore it results in very crisp boundaries whenever these adjacent structures meet each other. Like for example, the heart has a very clear boundaries, similarly the hemidiaphragms are clearly visualized, and this results in what is called as a Silhoutte sign, which means you can actually see the silhouette of the heart as well as the diaphragms quite well. uh, an absence of this Silhouette sign indicates that there would be pathology wherever there is absence. Now, to know where the disease is, we need to first and foremost know what kind of adjacent structures there are to all these denser tissues. Like for example, the left heart border is adjacent to the lingula of the left lobe, left lung. Right heart border, on the other hand, is next to the right middle lobe. Left hemidiaphragm is adjacent to the left lower lobe. The right hemidiaphragm is adjacent to the right lower lobe. The aortic knuckle is next to the left upper lobe or the middle mediastinum. Descending aorta is next to the left lower lobe, and right paratracheal strip is next to right upper lobe, and paraspinal lines are next to the posterior mediastinum or medial lung. Now, lack of these or abnormal infiltrates next to these crisper tissue or expected crisp lines indicate the presence of disease. Say for example, number 1, which is next to the left heart border, indicates the presence of a lingular disease. Number 2 on the right side indicates, sorry, I've mentioned left lower lobe disease, but it indicates a right lower lobe disease. Number 3, which is next to the paratracheal strip, it indicates the presence of a paratracheal disease. Chest wall, on the other hand, on the 4, indicates either a lung, rib, or a pleural disease. Number 5, which is next to an aortic knuckle, indicates the presence of an anterior mediastinum or left upper lobe disease. Number 6, which is basically just next to the spine, indicates a posterior thoracic disease. Number 7, which is next to the right heart border, indicates the presence of a middle lobe disease. And similarly, above horizontal fissure on the number 8 indicates the presence of the right anterior segment of right upper lobe disease. Now, these diseases may be either infiltrates, or they might be consolidation, or they might even be tumor, and therefore you basically need to have a differential whenever you see, depending upon the appearance and the description that you have to give, that you will talk about the differentials.